Okay, good morning, everyone. We're going to get started. Welcome to the training on COVID-19 case interviewing and contact tracing. My name is Darcy Richardson, and I am a nurse consultant. I'm an infectious disease specialist. Normally, I'm working in tuberculosis, and normally I'm working internationally, but I started doing tuberculosis work for the state of California way back when, and I was a program liaison there with some of the counties that we're working with now, and also I was the first outbreak response officer for tuberculosis in the state. So my experience comes from tuberculosis. A lot of things about TB contact investigation are very similar in terms of principle. We're going to see what the differences are today in terms of the epidemiology of this disease and the characteristics of COVID-19. So if you've done any tuberculosis contact investigation, this will seem familiar to you with some very important differences. I'm just going to go quickly through the agenda so you know what we're doing. And just for a few housekeeping things, please, if you're joining us on Zoom remotely, mute your microphone. And if you don't want us to see you in your pajamas or doing whatever you're doing at home, turn off your video as well. For those of you in the room, if you have questions, you can just raise your hand. If people on the Zoom have questions during the presentations, feel free to put those in the chat box or just unmute yourself during the questions and answers. So after this brief introduction and the agenda review, Dr. Sundari Mace, who is our County Health Officer, will be giving us a welcome and just a brief update and background on why we're doing this. Then Lucinda Gardner will provide us an update on and some background on COVID-19 itself and the epidemiology specifically in Sonoma County as well as globally. Rachel Reese will give us, who is our Director of Laboratory Services, will give us a lab testing update. Then I and the communicable disease team will give you the very brief Reader's Digest version of what you have to do effective case interviewing and contact tracing of COVID-19 patients and their contacts. And we'll have a very nice demonstration of how this works in real life from Miranda Patrick and Mark O'Neill. And then Lucinda will come back and give us some information about how you actually fill out the reporting form that needs to go into the CalReady system. And then we'll have, I hope, plenty of time for questions and answers. So without further ado, I would like to introduce Dr. Sundari Mace, who is our County Health Officer.
Great. Hi, everybody. Thanks so much for participating. I'm really excited to be here today. And Darcy and I worked together about 20 years ago and worked together for quite a while on outbreak investigations and all the stuff we're going to talk about today. So I'm so happy she's here to help us out. I want to give a little background on the situation. And thanks to all of you on the line for participating. This is being recorded. So if anybody wants to go back and review what we're talking about or have other staff members view this, it'll be available. So why are we doing this? Well, in tuberculosis, we regularly do contact investigation because it's the way that we find our new cases. And it's the way we find people that are latently infected. In this case, it's a novel coronavirus. You know, we don't really have strategies in place to guide us and for regularly or have a plan in place moving forward for everybody. So we want to instigate intensive contact investigation because we want to nip this in the bud along with our mitigation strategies. So in our county, we're kind of lucky in the sense that we're not quite where the counties south of us like Santa Clara, San Mateo, San Francisco are. But even those counties have realized that besides just doing mitigation factors like shelter in place, social distancing, personal hygiene measures, keeping people away from long-term care facilities, these are all helpful. But for communicable disease, as many of you know, the key thing is to find your cases and interrupt transmission. Okay, so that's the key. Find your cases, interrupt transmission. And the way to do this, since this is spread from person to person by close contact and is airborne, is to identify people who are most likely to be infected by the person who's diagnosed. And that is classic contact investigation. So often we'll go to the household and then to other close contacts. Darcy and the nurses are going to be talking much more about how we identify those close contacts. And then once we identify close contacts, we want to rule out active infection in those persons and follow them for the period of time that's been recommended by CDC to ensure that they don't become a case. And by getting them out of the community, we can interrupt transmission to other folks in the community. So this is really the basic tenet that we're going to go into. And I feel jumping on that now with our 54 cases is a good way for us to really try to make an impact on community transmission from here forward. So hopefully our curve will be flattened by this activity. I'm not saying it's not resource intensive. It is incredibly resource intensive, as all the nursing staff and the PHIs and people involved in this activity know. But I think we need to move forward towards it with the resources we have, and let's see how it goes. So of course we have other mitigation strategies. We have the health officer order for shelter in place, the health officer order for park closure. We've got an order in place keeping visitors out of skilled nursing facilities, even though shelter in place arguably does the same thing. And we put out all kinds of recommendations for individuals at the same time. So this is a multi-pronged approach. Remember, we have no precedent for what's happening right now. And that's why it can be a little scary. So rather than being, I suppose, paralyzed, let's jump into it and do what we can. So having said that, I'm going to turn it over. I think we have Lucinda next. So we'll get her, she's remote, so we'll get her on the line.
Yeah. Great. Lucinda, you're on.
Okay, great. Well, thank you, everyone. I'll go ahead and get started. So first, I just want to give you a background of about coronaviruses, and if we can go back one slide, that would be great. This novel coronavirus was identified in December 2019 in Wuhan City in the Hubei province of China, and it was initially detected as a cluster of pneumonia cases with exposure to a local open air market. Coronaviruses are enveloped single-strand RNA viruses that infect both animals and humans. There are 4 common strains that circulate worldwide, and they have very memorable names: 229E, OC43, NL63, and HKU1. And these are significant contributors to the common cold, and they circulate every year. And then now we have 3 more that have been identified that have jumped from animals to humans. The first is SARS, severe acute respiratory syndrome. And between 2002 and 2004, this caused over 8,000 cases with 774 deaths. That gives it a 9.5% case fatality ratio. Cases were identified in China, Hong Kong, Taiwan, and there was an outbreak associated with healthcare in Toronto, Canada. There were 8 cases identified in US residents, all with travel exposure. And then bats were identified as the reservoir, and it was likely transmitted to humans via civet cats. And then the second one was Middle East respiratory syndrome, or MERS. And this has been causing illness from 2012 to present, with 2,494 cases and 858 deaths, which gives it a 34% case fatality ratio, much higher. The majority of these cases were in Saudi Arabia, and there were 2 cases identified in US residents with travel to Saudi Arabia. And again, bats were identified as the reservoir, likely transmitted via camels. And that brings us to the 7th most recent coronavirus, known as SARS-CoV-2. And I just wanted to go over the nomenclature because this is a little confusing. So the disease is COVID-19. CO standing for corona, vi for virus, and D for disease, so COVID-19. And then SARS-CoV-2 is the virus itself. And it's very similar to the original SARS virus, which has been renamed SARS-CoV-1. So this is the timeline, and some of these slides I'm sharing are from Gary Green's grand rounds that he gave at Sutter, and so this has a couple of Sutter benchmarks in it, but it's a really great timeline, and several of the slides are from his talk, which is really good. So in December 8th of 2019, this is when they really think that it started, severe respiratory cases in Wuhan, China. And then at the end of the month, on the 31st, China reported to the World Health Organization that they had discovered this pneumonia outbreak of unknown etiology. By the 7th, they had identified the novel coronavirus and published the viral sequence. And then on January 11th was the first fatality in China, a 61-year-old male. And then on January 20th, the NIH announced that they were working on a vaccine from a previous SARS platform. And then on the 21st, we had our first case in the United States, and the CDC activated their Emergency Operations Center. On the 22nd, China moved to close all public transportation within Wuhan and Hubei province. And then the 24th is Sutter Health activated their emergency incident command. On the 30th, the World Health Organization declared a public health emergency of international concern for the new virus. On the 31st was when our first restrictions on foreign nationals traveling from China in the last 14 days went into effect. On February 7th, Li Wenliang, an ophthalmologist in China, died of coronavirus. On February 11th, the World Health Organization names the disease COVID-19. And then on February 25th, NIH announces the clinical trial with remdesivir. And then on February 26th, a person was designated to be in charge in the US government. This just shows you an overview of the timeline of the outbreak in China using the maps. So you can see on December 31st, it was really restricted to Hubei province. By January 10th, it was in 113 counties and 20 provinces. By the 20th, 627 counties and 30 provinces. By the 31st, over 1,000 counties and 31 provinces. And then by 11th, throughout the country, 1,386 counties and 31 provinces. And then on the bottom, this is just showing the epidemiologic curve. So the number of confirmed cases in blue, suspected cases in green, clinically diagnosed in orange, and then asymptomatic in red. And so you can see their epidemiologic curve. And then this is also one of my favorite graphs. This is from the Chinese CDC. And there's a lot of information on here, so I'll orient you to a couple of points. If you look at the blue bars, that is onset date. And then if you look at the orange bars, that's by date of diagnosis. So you can see that actual delay in diagnosing cases versus their onset. And then you can see just a couple of important benchmarks at the bottom. On December 26th, there were the first 4 cases of pneumonia in the same facility. And then on the 30th, 3 more cases found in the hospital for a total of 7, and that's when they reported it. And then you can also see the Lunar New Year holiday, which was definitely a complicating factor in yellow at the bottom. And then on January 30th, the World Health Organization declaring this a public health emergency of international concern. And this is a report from the Journal of the American Medical Association, which summarized a report that actually came out from the Chinese Center for Disease Control and Prevention. And there are a couple of key things. This was an overview of the first 72,314 cases in China. Confirmed cases, 62%, suspected cases, 22%, diagnosed cases at 15%, and then asymptomatic 1% of their cases. The age distribution over 80 years, 3% of all cases. 30 to 79 years were 87% of their cases. 20 to 29 years, 8%, and then 10 to 19, 1%, and under 10, 1%. So you can really see that they're just not finding a lot of cases in children. And then I think what's really important, the spectrum of disease of the 44,000 cases they knew about, mild was 81%, severe 14%, and then critical 5%.
Mm.
And then the case fatality ratio, 2.3% of all cases, and this was 14.8% in persons aged 80 and older, 8% in persons aged 70 to 79, and then 49% in critical cases, those admitted to the ICU. And this is showing that same data broken out into 10-year age groups. So you can see that in the older age groups, 80 plus, 14% of cases. And this is a 14% case fatality ratio in those 80 and older. Okay, next I want to move on to the current situation. So globally, there are 701,525 confirmed cases with 33,174 deaths. And then in the United States, a little bit about our timeline. Specifically, the first case was reported in a returning traveler in Sonoma, Washington on January 21st, 2020. And if you hadn't heard, this case is very interesting. This is a person who had traveled to Wuhan, saw a CDC health alert, and then self-presented to medical care. I believe they did call ahead and say, hey, I saw this alert. I think I might have this. And so it was just a great example of someone being incredibly aware of their exposure and then presenting to medical care. The first case of suspected community transmission was reported in Solano County on February 26, 2020. And then the first death was reported in King County, Washington on February 29th, 2020. And then now, as of March 29th, there are over 131,000 cases and over 2,300 deaths. And this at the bottom is the CDC graph showing the reported cases by state. And this also just shows how heavily New York is impacted with 5,000 or more cases. So this is the CDC's published EpiCurve. There are cases by date of illness onset. And this is only 17,000 of the cases because I think there's a huge delay in reporting as far as getting the information entered and CDC. But this is at least a proxy of our EpiCurve. And then you can see at the end of that, that's not really cases dropping off, that's just the reporting delay. And this is the California update from my new favorite website. Thank you, Darcy. This is the Microsoft Coronavirus Tracker, which is incredibly easy to use, of the great interface. You just type in your location and it brings it up. Very comprehensive. And so this is what it's showing in California. Over 4,000 cases, 4,643 active cases, 6 recovered, 101 fatal, and then you get, this isn't a live picture right here, but if you go to this site, it's interactive and you can click on your county. And then at the left, you can see that compared to the United States and the global numbers. And then if we want to look at our Bay Area neighbors, this is from our dashboard on SoCo Emergency, put together by our GIS team. In Alameda County, 256 cases with 6 deaths. In Contra Costa, 168 cases with 3 deaths. In Marin, 68 cases with 1 death. Mendocino, 3 cases. Napa, 9 cases. San Francisco, 308 cases with 4 deaths. San Mateo, 274 cases with 6 deaths. Santa Clara, which we've all been watching from the beginning, 591 cases with 25 deaths. Solano County, 34 cases with 0 deaths. And Sonoma County, we're up to 58 as of this morning with 1 death. And a little bit more about our Sonoma County cases. So we've had 58 diagnosed among Sonoma County residents. We did have 1 case that was a Diamond Princess traveler that's been excluded. That was a non-resident, but that did spend time in our county being treated by one of our local hospitals. So we've had 12 cases associated with travel, and this includes 2 from the Grand Princess Cruise, and sorry, that's out of date, and 10 others. 11 associated with community transmission, 10 cases associated with contact to a confirmed case, and then 25 under investigation. And then I also just wanted to include our link to our story map, which has up-to-date information. If you'd like to go ahead and click through that and get more information. It's updated twice a day, and then on the weekends once a day. So it's usually the most up-to-date numbers. So I wanted to just present a little bit of our epidemiology. So 22% of our cases that we've discovered so far have been hospitalized. That's 13 out of 58. Right now it's a 50-50 split between men and women, and this has been the same from the beginning. And this is a little different than China and South Korea and Italy, where they've seen more cases in men. As far as our distribution among age group, we've had no cases in 0 to 17-year-olds. And can we go back, sorry. 28 cases in 18 to 49-year-olds, 20 cases in 50 to 64, and cases in the 65 plus age group. And then I wanted to share this slide, and I'm sorry it doesn't present very well, but this is our timeline. And so in the dark are our cases by onset date, and in the light blue are our cases by diagnosis date. And then in the orange is just a couple of our interventions. So our began on March 7th at our Sonoma County Public Health Lab. And then on 3/18 was when we put in place our health order. So you can see that we've had cases dating all the way back to February 16th, just trickling in. And then on March 7th, when we begin testing, of course, we start seeing more cases in the light blue, but you can see the onset dates are stretching back quite farther than that. And hopefully, as we continue to see this, we'll hope it to flatten our curve. Before I move on to this next section, talking about pandemics and interventions, does anyone have any questions about the epidemiology or the case? Okay, great. So what does onset mean? So when we, we'll talk about this later in detail, but when we interview the cases, we ask them when their symptoms started, and then we'll collect the whole spectrum of symptoms, and then whatever that first symptom is, that is what we're considering their onset date. And most often, you know, this particular coronavirus has had a constellation of symptoms, and sometimes the symptoms in the beginning are quite mild, but because we're using the onset date to determine who is potentially exposed, we're very conservative. So if someone didn't feel good for a couple of days and they were achy and maybe a little feverish but didn't take their temperature, we'll use that day because again, we want to find out what their potential exposure is to other people. Okay, other questions? My thought is that we don't have testing sufficiency, so our numbers are much higher. Your thoughts? That's certainly possible. I do think that testing has been opened up quite a bit now through most providers. You can do LabCorp and Quest, and Kaiser is doing their testing. So I hope that we are diagnosing a higher proportion of cases, but it's certainly possible that there are many more cases out there we're not aware of. And then someone asked to clarify between 54 and 58. Yep. So yesterday we had 54, and then 4 new cases were diagnosed yesterday, bringing our total to 58. And then as far as how many tests are pending, we're no longer tracking that because we can only track the number that are pending at our public health lab, and that varies day to day. And then we don't have any idea of how many are pending at private commercial labs. And so that next question is a question for Rachel. I don't think we have the FDA approved 45-minute result test kits. I have heard about that, but let's bring that up again when Rachel does a presentation. She may have a better update. Okay.
Are the airborne or droplet? Somebody's asking. True airborne or droplet?
Dr. Mace, do you want to take that one?
Yeah. 1 second, everyone. What was the question? So is it a true airborne or droplet?
You mean for precautions?
No, just transmission.
Yeah, transmission is droplet. I mean, we're finding that the virus can live in droplet nuclei, and that's the airborne transmission is in that manner, but probably contact is a more common form of transmission in this case, you know, so that's why we're really worried, I think, you know, that's why we're making all these recommendations for using hand sanitizer and cleaning surfaces and all stuff. But both forms of transmission are occurring. I mean, I don't know what you mean specifically about it. It is all airborne transmission. What we're suggesting is that you take droplet precautions, meaning you don't put people in negative pressure rooms when they have coronavirus or they're suspected of having it. I mean, I don't know. Darcy, do you want to add to that?
I just want to say, first of all, there are going to be a lot of questions. They're really good questions. We will answer all of those questions during the Q&A session. So let's try to keep it to the minimum so we can get through all the material, because I think a lot of your questions will be answered by subsequent speakers. In terms of coronavirus, it's both airborne transmission. So you're breathing it in, somebody who's sick is coughing out, you're breathing in some virus. And the other means of transmission is through fomites, so surfaces. You're touching a surface, then you're touching your face, you're ingesting those viruses through your nasal passages, through your mouth, etc. And that's how it's transmitted. And it's incredibly virulent compared to the other viruses that we've seen lately. So this is why it's important for us to be very careful about what we're touching, how we're using our hands, our hand sanitation practices, etc. But we're going to get to all of these details. You've asked a lot of really good questions, and I think we're going to answer them in the next couple of presentations. All right, Lucinda, back to you.
Okay, and I just wanted to go back to one question because I reread it and I misunderstood, and this is important. So on the graph, it has 54 cases, and I said that we had 58. So with the cases that came in yesterday, they haven't had an interview done yet, and so I don't know their onset date. So I can only really include them in this figure if I know their onset date. So thank you, that's a great question. What is a pandemic? Okay, so the official definition is an epidemic occurring worldwide or over a very wide area, crossing international borders and usually affecting a large number of people. And we have certainly met that definition here. And the World Health Organization declared COVID-19 a pandemic on March 12th. So why is this different from other disasters? Every community will experience the pandemic as a local event. And California is such a great example of that. You can see a huge range of how this is even affecting different counties, looking at Santa Clara with their cases to counties that still haven't diagnosed their first case. It can happen in many places at the same time. It can continue to spread illnesses in waves that can last for a year or more. Because everyone is experiencing it, there's limited assistance from federal, state, and other sources of mutual aid. Disasters tend to affect a local region, and this is affecting everyone. And then it's different because the whole community needs to work together to respond effectively. I also want to talk a little bit about containment versus mitigation. We're hearing this a lot in the news. Containment is restrictions on movement, travel monitoring, isolation and quarantine, and intensive case investigation. This is taking a person who is infected with a certain disease and then trying to contain what's happening by putting rings around them, doing these contact investigations, and trying to identify everyone who is exposed and then put in the proper systems so that they are not infectious to us. Mitigation is what we're doing on a broader scale. So you can use pharmaceutical measures if they're available, vaccines or treatment. And then if those aren't available, which in this case they're not, then we have to go to non-pharmaceutical interventions, social distancing, restricting public gatherings, and school closures. So in Sonoma County, we are doing both of these things. So containment, we're doing our ongoing surveillance for COVID-19. We're doing active case follow-up and recommendations for those exposed to known cases. And we're doing this intensive case follow-up, which is why we were having this training. And then we're continuing to do quarantine and isolation. And then for mitigation, there's individual, the hand and respiratory hygiene, don't touch your face, don't go to work when you're sick, wash your hands, and self-shielding. And then community, social distancing, restricting public gatherings, our health order, and then closing parks. And then I just wanted to close with the image of flattening the curve. So again, this is what happens. The red curve is what happens if you don't use protective measures. The disease will burn through the community and overwhelm our healthcare system capacity. And what we're trying to do is flatten this, and so we do not overload our healthcare system. So we're spreading our cases out over a longer period of time and hopefully reducing the overall number so that everyone can access medical care when they need it and safely. Great, thank you so much for your time, and I'll continue watching for questions and be available during the Q&A.
Thank you very much, Cinda. That was a great presentation. And we will have plenty of time, I hope, during the Q&A to go over some other questions. And now I would like to introduce Dr. Rachel Reese, who is the head of our laboratory services, to give us an update on laboratory testing, because I know a lot of people are wondering. Rachel.
Good morning, everybody. Thanks for being here and thanks for inviting me. So, as introduced, I'm the lab director of the Sonoma County Public Health Laboratory. However, we do actually serve 3 counties. We serve Mendocino and Lake counties also for lab testing.
Who are on the phone.
Who are all on the phone, so thank you. First, I'd like to go over a little bit about the process of being able to test specimens for COVID-19 in our laboratory. And currently, our Sonoma County Disease Control is screening specimens for testing, and well, Lake and Mendocino will be using their respective disease control units to screen specimens and patients for testing. And there is a prioritization system that is on the Sonoma County website. So I'm just going to read these. For prioritized testing, the following groups of people: individuals with signs and symptoms with or without fever compatible with COVID-19, and hospitalized and significantly ill, or healthcare personnel, including first responders with direct contact with patients, or All other first responders, such as fire and law enforcement, lives in or works at a long-term care facility, or is chronically homeless, or is an inmate or works at a jail or prison. And so if you have a person who has those symptoms and you think they meet the criteria, you would contact for Sonoma County Disease Control, and that number is 707-565-4566. And then they'll help you go through the criteria and screen. We are currently still using these PUI numbers, which might change in the future.
Can you say what PUI is?
Yeah, it's a person under investigation, and this was a number that was put in place by the CDC for epidemiological tracking. And at the state level, I heard it's no longer required, but we don't have a new system in place yet. So we're still using the PUI number system. So specifically at our lab, we are doing the real-time PCR test. It's the CDC COVID-19 EUA diagnostic test. And as somebody mentioned, there are a lot of other test platforms coming out now. I hadn't heard about the one that somebody mentioned that was the 45-minute turnaround time. I would suggest if you're looking at one of these alternative tests that you go to the FDI website and see that they actually do have their emergency use authorization in place and that they've complied with all the regulations. I have heard that there are a lot of actual intentional scammers out there coming up with things, so be sure to vet your lab test very carefully. So maybe at this point you've been approved to test at Sonoma County Public Health Lab. What we would need from you is our laboratory requisition form, which is actually a paper form. When we're making our specimen collection kits in the lab, we will insert a paper form in there. Oh, I still need to update the website. You can also get it from our website, but right now I think our previous version of the form is there. So the other thing is regarding specimen storage and transport. So we have a lot of different, because of the shortages, a lot of different transport media, which is the liquid part that's in the tube. We have a lot of those coming through. Some of them can be stored at room temperature before collection, but others need to be stored refrigerated before collection. So just be aware of that and maybe check the label or ask the person you're getting the collection kit from. But they all, after you collect the specimen, they all have to be maintained refrigerated at 2 to 8 degrees. So
what about materials for collection?
Yeah, I was just getting there. So there are a lot of different specimen types, like not only specimen sources, like where can you collect it in the respiratory tract, but also like the physical tool that you would use to collect it. So when you're, just to go over like the physical kind of part of the kits, the different transport media, viral transport media, which is VTM, universal transport media, which is UTM, viral chlamydial transport media, which is VCM. So these are things you want to look at on the label. We are starting to make sterile saline in our laboratory. We validated that and it was approved for use by the CDC. And then liquid amines, which many of you might know as an e-swab. So just look at the e-swab label if you have that and use the liquid amines one. And then as far as the swab, if you're collecting a swab, you might have read the CDC website. It says, you know, use synthetic swab fibers. And you might be asking, what does that mean? Well, some of those would be a flocked tip, a foam tip, a Dacron, rayon, polyester, or nylon tip. And that would be with either a plastic shaft, which is preferable because they're easier to break off in the transport tube. But there are some with like aluminum wire shafts and they are fine for the test. They're just kind of a pain for the collector because you're going to need a pair of sterile scissors to snip that swab off into the tube. Some things that we'll be rejecting are non-sterile swabs, cotton tip swabs, wooden shaft swabs, calcium alginate swabs. We have a swab that went into, there's a media called gel amines. So don't confuse it with the liquid amines. We're not going to accept a swab that's in gel amines. And then other bacterial culture swabs. So I know it's kind of it's a lot of material, and I do send out a lab email update. And if you're not on that list, you just reach out and I can email these specimen requirements to you. So let's talk about actual specimen types, like where are you collecting it? So first I'll go over lower respiratory tract, and this is probably, for inpatients and if clinically indicated, the bronchoalveolar lavage or tracheal aspirate and sputum. And I think those have, lower rates of false negatives, are probably the best specimen type to collect in terms of sensitivity and specificity. And then, oh, did you want to say something?
Is sputum potentially going to be an alternative collection, because that's easily collected in the outpatient? That's what I'm wondering.
Right. So it would be.
Repeat the question because people. Oh, sorry. Yeah. The question.
Oh yes. Dr. Mace was asking if sputum is actually an acceptable type for outpatients, collecting in that arena, and it is. It's an expectorated sputum. You don't want to do any induced sputums because of the aerosol transmission or droplet transmission. But we did validate sputum in our laboratory. There's a different process because of the mucoid nature of it. So we had to verify that process in our lab. So if you have somebody with a productive cough and you want to do an expectorated sputum, that's fine to submit. So most specimens, I think right now, are going to be from the upper respiratory tract. So these are going to be primarily different types of swabs. So initially the CDC was recommending separate nasopharyngeal and oropharyngeal swabs, and those were in separate tubes. And as they got more data and then swab shortages started occurring, they went with the NP-OP combined swabs. So this is, it could be either two swabs. You could use one swab to do the throat swab and then a separate swab to do the nasopharyngeal swab, but both swabs go into the same transport tube. If you only have one swab, hopefully it's a nasopharyngeal swab, and it's still best to first collect the throat specimen with that and then the nasopharyngeal and put that swab in the transport media, because you're going to have a higher sensitivity for the test. You can do, the CDC is recommending an NP only swab now, and I think, that might be related to shortages. They have some data supporting that it's okay. But like a couple laboratories in Southern California have indicated that they were still getting discrepancies between NP and OP swabs. So I still think that an NP swab alone has a lower sensitivity than a combined NP-OP swab. And then also acceptable are oropharyngeal only swabs. And they have the CDC just added nasal swabs, which is either self-collected or healthcare worker collected, and a nasal turbinate swab. So those three types of swabs, there's still not a lot of data. I think there was enough data to support them kind of being okay for testing, but I still think they'll have a lower sensitivity than an NP or a combined NP-OP swab. So we will test them at our lab, but we are reporting them with a disclaimer on those due to the potential for false negatives. So there is not very much data out there regarding the sensitivity and specificity of these specimen collection types. I've seen one study from Singapore and another from China, and I guess false negatives in those populations were as high as 37%. So you just might want to use your clinical judgment to determine if you want to retest a person. Sometimes a person might be tested in the outpatient setting and then get sick and go into the hospital. You might want to retest if they're negative at the initial one. And the other specimen type that I haven't spoken about yet is the nasopharyngeal wash or aspirate. This does not require a swab. So if you're having a swab shortage and you have the ability to do nasopharyngeal wash, that is also a good specimen type. And I think because maybe it gets more material, it may have a higher sensitivity than the swabs. But again, I haven't seen any data. And that's about all I have. So do you have any
Turnaround
questions?
times for results.
Oh, thank you. So our test capacity right now is about 120 specimens per weekday. And that's with a next day turnaround time. And we've been doing great. A lot of our results are done the same day. If they are coming in more at the end of the day, then they'll be run the next day. So with changes coming up, I hope to be able to maintain that turnaround time. We're looking at ways to maybe expand our testing capacity because, 120 specimens a day is not a lot given the severity of the situation. We have a gene expert in our lab, so we're hoping to get gene expert cartridges for COVID and expand testing that way. And other than that, yeah, if we get inundated with swabs, we might have to extend our turnaround time, but right now we're doing really well.
I'm going to go back to my presentation now.
Wonderful. Thank you very much, Rachel. I'm sure there are lots of questions about laboratory. I want to emphasize that this training is really about case interviewing and contact tracing. So the laboratory testing update is for your information for most of you. We are not asking the nurses right now who will be volunteering to help us with contact investigation. We're not asking you to do testing. So I think somebody had asked that question and I just wanted to clarify that point. Okay, so we're going to go back now and I'm going to talk a little bit about how do you do case interviewing and contact tracing and why are we doing it? So next slide, please. So these are our learning objectives for this morning. This is the meat of what we're trying to get out of this training this morning. First of all, what is the importance of case interviewing and contact tracing? How do we flatten this curve and what role does case interviewing and contact tracing play in that? What are the core concepts and skills that you need to conduct effective interviews? What are the key elements of doing so? And we'll have a demonstration of that. And then explaining the structure and process of how this is going to work or how we think it's going to work in Sonoma County. And just know that as things change and evolve, we're going to have to be very flexible. So this is what the snapshot is for today, and things may change in terms of how we organize this later on. Next slide. Okay, so this is our goal, to break transmission chains to reduce morbidity and mortality in Sonoma County and of course the surrounding areas where people are going. So this is an actual network. It's a representation of a social network. And if you think of this blue dot in the middle as the index case or the person who is infected, then all of these connections out here are people that this person interacts with directly or indirectly through that person's social contacts. So it could be at work, it could be at school, it could be at home, it could be just out in the community or in church, whatever. So just to hit one forward. What we're trying to do with our case interviewing and identifying the contacts and screening them is to cut this chain off before it gets too far. So we're trying to reduce the number of people that we have to deal with, the number of people who could potentially be exposed, the number of people who go on to be cases and then have their own network. Okay. Is that clear to everybody, at least in the room? Okay. So why is this important? Thanks. When we look at South Korea, this is often held up right now as an example of very good disease control. And right now, as of yesterday, the US had almost 124 or 25,000 cases. South Korea has 9,478. We started at about the same time in this outbreak, and of course populations are a bit different, but the point is that they really shut this down very aggressively, and they took some draconian measures that would never work in the United States. But I think the important point is that there were some pretty straightforward things they did. They did it fast, they had widespread testing, they did very rigorous contact tracing, and of course they had support from people who really did stay inside. So this is the opportunity we have when Dr. Mace has talked and Cinda has talked about where we are in Sonoma County. We're really just at the beginning of this upward spike. So if we can do a really good job with finding the cases we have now and the people who have been in contact with those cases and really just leaving no stone unturned, we have a much better chance of flattening that curve significantly because we have all those other mitigation measures in place as well. So in terms of what are our priority activities right now, the first thing obviously is to find the cases. Where are they? Get them isolated and make sure they get treated. The second thing is to find and evaluate the people who have been in contact with those folks. So we're going to, what are we going to do with them? We're going to give them some guidance on their need for isolation, how they monitor their symptoms, and test them if they have symptoms and make sure that they get treatment in terms of supportive care because we have no drugs right now. Using targeted testing strategies for high risk or high exposure groups to identify cases. That's nice to do if we have the time and we have the resources. And then identifying settings at high risk, such as nursing homes, and making sure that we're applying effective infection control to try to prevent any sort of outbreaks in those settings. And what we're really talking about today is number 2. So we're not going to cover the other ones very significantly, but we'll touch on them. So what are some of the core concepts and skills that are required to do this particular job? We've already gotten some knowledge about COVID transmission. We have some knowledge now of the symptoms and disease progression, and in our demonstration, we'll talk a little bit more about that. What I'm going to focus on is the effective interviewing and patient education skills, and then Cinda will come back to talk a little bit about data management and analysis. And before we start getting into the discussion, it's, I think, important for all of us to be on the same page about some definitions. So who are contacts? In this case, when we're talking about COVID-19, it's any person who would be living with, working with, has had direct contact with, through church or whatever, has traveled with, we know a lot about cruise lines now, or has been at the same locations as a case during the time they have been infectious. So it doesn't have to be direct contact, it could be indirect contact. You just happen to be in the same place that they were recently, and you're touching the same surfaces. That's why we have hand cleaner everywhere. So if you live in an apartment building, it could be the other people living in the apartment. If you've been in a walk-in clinic, it could be the receptionist. If you've been in a grocery store, it's all of the other customers there, and it's also the checkout people.
Darcy,
Yes.
are you going to be getting some of these things written down and handed to us, or is this something?
I just want everybody to know, and I will say this to people on the phone, that the question was, are we going to get any of this information written down? The answer is, all the slides will be available. This will be recorded, and the information is available written down in other places as well. But we'll make sure that everybody has access to the presentations. So what is the infectious period? Somebody asked this question before. We're talking about the time period during which a COVID positive patient can transmit the disease to others. So we've talked a little bit about the symptom onset. When do you start feeling a little bit bad? And we know that people are not great historians when it comes to this. I'm thinking, you know, like, when did I have really bad sinus congestion? I don't remember if it was 2 days ago or a week ago. It was sometime in there. We also know that before the onset of symptoms, when people are asymptomatic, they can also transmit. So what we're doing is going back a few days before onset of symptoms, when symptom onset has occurred, and then for people who have disease right now, the definition is after the start of symptoms, when you become ill, it's at least 7 days after that, in addition to 3 days with no fever and improvement of your symptoms. So it's at least 10 days after you feel sick that we're defining the period of infectiousness for the purposes of both isolation, and for the purposes of contact tracing and limiting exposure, okay? I know this is a little complicated. It's all written down in the Sonoma County guidance. So why is this important to know? It helps us focus the investigation on the contacts who are at highest risk, especially if this investigation involves any sort of congregate settings or vulnerable populations. If you're talking about a homeless population, if you're talking about a population in a SNF or a skilled nursing facility, etc., or a prison or jail. And it sets the time frame for contact follow-up, and we'll talk a lot more about this when we get into the nitty-gritty details. But if we're talking about following up a contact to make sure that they're not getting sick and that they're quarantined during a period of potential infectiousness, it's 14 days after the last known contact with an infectious case. And we'll spend a lot more time talking about this. So what is contact tracing? Contact tracing is a systematic process. First of all, you identify who those people are. You assess them for symptoms and refer them for testing if it's necessary so that we can break those chains of transmission. We provide guidance to them on all of the contacts, whether they're symptomatic or asymptomatic, both groups, on quarantining and self-monitoring. So how do you assess yourself every day for symptoms? How do you take your temperature? How do you report? Give them information and reassurance. People are scared, especially when you've first been diagnosed or first identified as a contact. There's a lot of concern. So we have to provide people with some education, some reassurance that we're there to help them, and then follow those contacts up. So this is the meat of what people who are volunteering to support this effort will be doing, is working with contacts, making sure they have information, making sure their symptoms are tracked, and we're following them until the end of their quarantine period. Okay, so what is the process that we're going to go through? First of all, it's important to recognize when is contact tracing a feasible and effective thing to do. It's most effective and most feasible early in the epidemic when we have a lower number of cases, we have sufficient staff to do this, and we have sufficient testing capacity. So this is nipping things in the bud. As soon as we have a case, we're jumping on that. We are identifying all of that person's contacts who could possibly go on to have disease, and we're making sure we're following them, checking them for symptoms, and if they have symptoms, immediately getting them tested. So early in the epidemic, what we're trying to accomplish is doing a case interview and contact tracing for every single person. That's possible when you don't have very many cases and you have enough staff. Then when we start to see that curve accelerate, when we start to see that curve go up, we may have to go to some prioritized contact tracing. What are the most important cases in terms of the numbers of people they have exposed, the vulnerability of the people they have exposed, etc. And I'll talk a little bit more about this in a minute. And then when we get to the peak, if we end up with that big red curve, which we are hoping to avoid, you're going to be able to do only the essentials. You're going to be able to interview the cases, identify the immediately most exposed contacts, and make sure that they don't have symptoms. And that may be as far as we can go. So the sooner we get on this and the sooner we can really shut this down, the better off we're going to be. And that goes from, so this is really the spectrum from focusing on containment to focusing more on mitigation. It's not an either or, it's always going to be a combined thing, but we're emphasizing different things at different points in this epidemic. So as Cinda pointed out, this is our curve right now. We're starting to accelerate a bit here because we're getting more testing, for one thing, and because we're getting some community transmission. So we have an opportunity right now that we are not going to have a week from now or 2 weeks from now to really try to shut this down. And so when we're faced with these multiple cases, the communicable disease team will be getting reports of 10 cases a day or 20 cases a day, and it will start to get overwhelming. We're going to have to decide which cases should be higher priority for contact tracing. How are we going to do that if we have limited resources? First of all, potential exposures to large groups of vulnerable people, the elderly, the immunocompromised, people in congregate settings. That's a high priority investigation because it's high risk. First responders and healthcare workers, because we cannot afford to lose them. We need all hands on deck. And then closest contacts and the vulnerable contacts of all cases are always going to be the priority. So if you identify somebody who maybe just stays at home, but they have an elderly relative living with them, that's going to be high priority for follow-up. And then, so even within contacts, so we have priority investigations, and then within each investigation, we have priority contacts. So when you have that list, you're going to prioritize those contacts potentially on who needs to be contacted first. That is based on, first of all, the likelihood of transmission, which is usually around how long has this person been in contact with the other person or in an enclosed setting. The most contact, in other words, with the potential transmission. And then that individual's, that contact's risk of transmission. Risk of development of disease. So if they're immunocompromised, if they're elderly, if they're in a risk group, those are very important contacts. So we want to make sure that they're the first ones we're tapping. And it may not be the people in the home, because some people may be working a lot right now and not be in their homes very much. So it could be the people at work. So now we're going to talk a little bit about the steps in this process. And then we'll have a demonstration, so you don't have to take all of this in right now. Miranda and Mark are going to show us how this is done in real life. But the first step is a case interview. So the first thing you're going to do when a case comes in is make sure that you are talking to that person. And this, I just want to emphasize, this is being done by phone. You are not face-to-face contact with people. So PPE is not necessary for that purpose. Depending on where you're working, it may be necessary for other purposes. But for the case interview, what we want to do, first of all, is establish a relationship with that person. This is somebody who's sick, who's scared, who's concerned about their condition. So the first thing we have to do is introduce ourselves, provide them with some reassurances, give them some education about COVID-19, collect the information that's needed for reporting, and Cinda will be going over that in detail when we finish with this. Then, as we've talked about, one of the things you need to do is determine the date of onset of symptoms. Identify the contacts and get their information so you can follow up with each of them. And then identify locations visited and activities while this person has been symptomatic. So where have you been? Oh yeah, I took a plane flight to the East Coast. Okay, well that's something for follow-up. But talking about where people have been, who have you been socializing with? Have you gone to any sports events? Not that that's happening anymore, but you know, have you gone out to the grocery store? Have you gone to church? Whatever people have been doing during their infectious periods. Then explain the isolation process. What does that mean? And we'll go through that in some great detail. And then at that point, the patient is thinking, okay, well, I can't go out now. I can't get groceries. I can't get medicines. What am I going to do? So the follow-up to that is, well, what do you need to be able to stay isolated? What's going to make it difficult for you to be isolated? And how can we support that? So making sure they get connected to meet the needs that they have. Then giving your contact information so they have somebody to talk to if they have questions. Setting up a follow-up schedule if needed. Verifying their contact information, and then there is a packet of information you can email to them so they have all of this in writing, because we know that when people are first diagnosed with an illness, it's sometimes hard to absorb all of this information, so we want to have them in writing. And this may take more than one phone call, especially if people are quite ill. It could take some time to get in touch with that person. If people aren't forthcoming with information, it may take a couple more phone calls before they feel that they can trust you. So how do you identify contacts? As we said, what we just talked about, places where they've spent time, people with whom they have spent time, and what activities and events they may have participated in during the period they've been infectious. Okay, and then once we generate that list of contacts and you have prioritized who you want to talk with first, we're going to go to the contact tracing part of this, or contact investigation, depending on how you want to say it. I think tracing is a little bit nicer than investigation, so that's why I say that. Again, we're going to establish a relationship with that person. We're going to verify their contact information, explain the role of the health department in this process, give them some reassurance and education about COVID-19, assess them for the presence of any symptoms and educate them about what the symptoms are, referring people as needed for testing if they have any symptoms, then explaining the quarantine process and requirements, and we'll talk a little bit more in detail about the difference between quarantine and isolation. Assess their ability to be able to quarantine at home. So do they need to be removed from that setting because they have other vulnerable people in the household, etc. And then provide guidance to them on how they're going to self-monitor and provide self-care for them for their quarantine period. Assess their needs during their quarantine, and then establish a schedule for follow-up. And that is going to be probably for 14 days at least if they're asymptomatic. And then provide your contact information. So that's the basic process. So if a case is found among the contacts, one of the things you have to remember is if they're now a case, then you're starting this process all over again. So they then go to the case interview. You're going to interview them again about where they've been, and you're going to generate another list of contacts for that person. So it's a chain. That's just important to remember. And then in terms of confidentiality, and we'll talk about this more during the demonstration, information is only shared on a need-to-know basis. So all of this information is confidential. When you make a phone call to a contact, you are not saying, oh, you're a contact to so-and-so. You're not providing information about the case. You're saying, you've been exposed. We understand you may have been exposed to COVID-19. So we're not sharing that information with each contact. They may already know because somebody may have, their friend may have called them or their colleague may have called them, but it's not our job to inform them about with whom they may have been in contact. And paperwork with personal identifiers, as usual, confidential information, keep it in a locked, stored place. Okay, these are the specific guidance rules, and I will rely on our CD team to answer any questions about this because it does get a bit complicated. So what does it mean to be isolated? Isolation, when we're talking about isolation, it's a person who is currently ill and contagious and has to stay away from other people. So these are our COVID-19 confirmed cases. They have to stay in isolation and hopefully at home. If we're lucky, they can stay at home, except to get essential medical care. That's the only reason they can go out. So these are the requirements. You need to call your medical provider ahead of time if you need to go to your provider so that there can be appropriate infection control procedures set up at the site that's receiving them. If you have to go to the emergency room, if you're feeling really sick, you need to go to the hospital, you dial 911. The dispatcher should know that you have COVID-19. So these are all the things you're going to go over with people on the phone. If they are a case, you want to make sure they understand these things. If they need groceries or other essential items, they need to be delivered. If they can't get them delivered, if you need help doing that, then they should contact public health and let them know. There needs to be separation in the household as well. So they should be sleeping in a separate room, using a separate bathroom when possible, or decontaminating, cleaning the bathroom in between uses, wearing a face mask if you have to go into shared areas, and avoid sharing other personal household things. And then obviously good hygiene and respiratory hygiene. So covering your cough or sneeze if you're not wearing a face mask, washing your hands all the time, either using soap and water or an alcohol-based sanitizer, and cleaning those surfaces like doorknobs and countertops and toilets and faucets and sinks that people are touching frequently. Okay, how long does somebody need to be isolated? We already talked about this. How long they've been contagious after symptoms developed. So it depends. The answer is it depends. But for non-healthcare workers or people who aren't working with a vulnerable population like the elderly, then a minimum of 7 days after symptom onset and 3 days of no fever without taking Tylenol or other antipyretics, and your symptoms, other symptoms are improving. Okay, so that's at least 10 days. Then there are particular rules for healthcare workers and people who work with elderly populations or other vulnerable populations. And these are all written down. As far as I know, they're on the Sonoma County website. Right, Dr. Mace?
Yes.
Yes. So these are all on the, you don't have to try to remember this. There is somewhere you can refer. So healthcare workers should be isolated, again, for at least 7 days after symptom onset, plus the 3 days with no fever and improvement of symptoms. And if they return to work sooner than 14 days since symptom onset, so if they have that 4-day period where they're returning to work, they need to wear a surgical mask and avoid those vulnerable patients until at least 14 days after symptom onset, which essentially boils down to, if you go back to work after your 10 days, you have 4 days where you really need to wear a mask and stay away from vulnerable populations. This is the CDC guidance. They did this because they recognize the need to have healthcare workers go back to work as quickly as possible. Okay, and then for people who work with elderly populations, it's the same as healthcare workers in general, except you're going to get tested at the end of your infectious period, and you're going to do 2 tests 24 hours apart, and they both have to be negative before you can go back to work with these vulnerable populations. Okay? It's a little bit complicated. Once you get familiar with it, it gets a lot simpler.
Can I just ask, so if they have, if they're not positive for COVID-19 but have other flu-like symptoms, that's different than this, or is it on the same protocol?
Dr. Mace can answer that question. So the question is, if they're ill with flu-like symptoms but they're not COVID positive, what happens to those people?
Yeah, so if those folks haven't been tested yet, we ask them to self-quarantine until they get the test, if they're getting the test. If it's negative, then they're not subject to these kind of isolation requirements.
However, if they have flu-like symptoms, we might want to keep them away from vulnerable populations.
We can
and
tell
certainly
them,
wearing a mask.
We can tell them until your symptoms resolve, stay at home, but these specific recommendations don't apply.
Just in terms of optics, I think it would make people very nervous in a setting if you have somebody who has COVID-like symptoms who is not at home. We're trying to keep everybody who's sick at home because we know the test is not 100% perfect.
That's a really good
point. Okay. So then what does it mean to be quarantined? So this is somebody who's been exposed to somebody who has COVID-19, is at risk of becoming ill and spreading the disease to others. This could be somebody who has symptoms or doesn't have symptoms, either one. So if you've been identified as a contact and you have a reasonable risk that you may progress to disease, we know you've been exposed, you're in the household, or you're a close contact, then all of those folks are being asked to quarantine, self-quarantine at home if possible. So they need to stay at home again, except for essential medical care. It's the same routine as people who are COVID positive in terms of going to your provider or asking 911 for assistance. And again, you should not be going out to the grocery store. You should be staying at home. And in this case, we're monitoring people for symptoms on a daily basis. So you're taking your temperature and assessing whether you have any other symptoms, and we'll be in contact with the public health department. So in other words, somebody's going to be calling this contact once a day or once every 3 days and saying, hey, do you have any symptoms? Do you have a fever? Is there anything I can do for you? Etc. Okay. So this is a lot of what the volunteers or the additional staff who are coming into this process will be doing during the course of these investigations, is contacting the contacts and making sure that they're okay and they have not developed symptoms, in which case we immediately refer them for testing. So they also need to separate themselves from others in the household who have not been exposed, if there is anyone. Sleep in a separate room, use a separate bathroom, the same kinds of things. If there are contacts to the contacts, they don't need to be quarantined unless that person develops symptoms, in which case, okay, we're thinking that maybe they have now been exposed. And then again, practicing good hygiene, the same as before. So how long do people get quarantined? So these are people who are not necessarily, they're not confirmed cases. They may be symptomatic, waiting for test results. They may be asymptomatic. We're asking them to stay at home in quarantine for at least 14 days. And if you're a household member who has a COVID positive case in your household, your clock starts ticking from the last exposure you have to that person.
If that's ongoing.
If it's ongoing, then it's when the person's symptoms resolve, then your 14 days starts ticking.
Right. This is a reason.
This is when it gets a little hairy and complicated, is when do we say, if you're in a household, of course, we're going to try to keep those people isolated. And if you're COVID positive and for some reason you have vulnerable people in your household, we're going to ask you to move somewhere else. That's one of the reasons we're setting up the alternate care site, is so that people who have other vulnerable members in their household have a place to go if they can't go to a motel and isolate there. Okay. We'll get, there are going to be a lot of questions about this, I know, but the nurses are far better placed to answer some of these questions than I. So that's the situation in which you have household members who are exposed. If we're talking about healthcare workers and emergency service workers, there may be an employee health policy, so we need to conform to that. And they may be able to return sooner than 14 days, especially if they're essential personnel and we really need all hands on deck and they're asymptomatic. So that's one of the situations where it depends. Then for first responders, childcare workers, essential workers, 14 days since last exposure. Again, it's similar to other services. And people who work with the elderly populations, absolutely 14 days since the last exposure, because we know that the mortality in that population is very high. So the consequences of having somebody come back into that setting are very high. Okay, now we get to the interview. And so what does the interview do? First, we're getting critical information from cases and their contacts. So we're not having a nice long chat about, you know, where they're going to go on their next vacation and how many, you know, what they've been doing. We're really focusing this on the information that we have to get. Other important thing to know is these skills can be learned, and it takes practice to get really good at them. And our communicable disease team has had a lot of practice doing this. So what we're going to do is give you a demonstration of what a case interview and contact conversation might look like. And then for the people who are new to this, who are coming into this, who haven't done this before, we'll make sure that you have the opportunity to shadow an experienced interviewer so that you get the hang of this as you have to go through this process. And just in terms of tools and resources, we have the interview forms. So you'll have a set kind of script and reminders about what you need to ask. Obviously, the CD team and the nursing directors are treasures, our gold mine of information. And then Dr. Mace and myself can also be helpful in this process. So I am going to stop right now and let you all do your demonstration. I'm sure it's going to bring up a lot of questions. We're going to try to hold that until the end. And then I'm going to talk a little bit about just the mechanics of this, what we're thinking of for the structure for Sonoma County, and wrap this part of it up and then go back to Lucinda.
So let's stop for 1 minute, just grab lunch here.
Oh yeah,
and come right
okay.
back
So,
during the interview.
for those of you who need a bio break or who want to grab something to eat or change out of your pajamas, whatever you want to do, we're going to take a 5-minute break and reconvene at 12:25. Okay?